so okay, so let's start with this case. So this is 28-year-old Caucasian female brought to the emergency due to a sudden onset of shortness of breath and swelling of her lips, face, and extremities. Okay. Now her labs BP is 100/62, pulse is 126, respiration is 38, temperature is 98. So, okay, so her full history, she just presented with sudden shortness of breath and asymmetric edema of the body after a bee sting. Okay. She denies any medical problem. Her other history is unobtainable. So she just had sudden shortness of breath, swelling of the lips, hypotension after a bee sting. So where do you want to do? So this is like some sort of anaphylactic shock. So what do you do? No, she's in the emergency room. So
IV access,
yeah,
fluid,
let's do
epinephrine.
police BS, the pulse oximetry, oxygen. Let's do cardiac monitor. Police. Let's go by sequence. IV access, IV fluid, cardiac monitor, BP monitor.
What's L in the police?
Intubation. If there's lung mean like intubation. If
L
there's,
is
do you wanna intubate this girl? Or?
No, I didn't say intubation. I said epinephrine, EpiPen,
Yeah, the epinephrine. Yeah, first we start. BP monitor, finger stick glucose, epinephrine. That's the most important thing. Okay, so what else? Anything else?
No, I think this is just an anaphylactic shock. So
Yeah, so this is acute presentation, so let's act fast.
So she should be okay with EpiPen.
Yeah.
I mean EpiPen, epinephrine. We will admit her for sure. I'm not gonna discharge her. I'm gonna observe her.
Yeah.
Yeah.
Let's give IV bolus to normal saline.
Normal saline, yeah. I said that. I think it's supposed to be IM, no?
Bolus, huh? Yeah, I am. Yeah, that's true.
You give IV, I think.
Yeah, I'm gonna change it. Bolus, I'm just gonna put bolus normal saline. Yes. Okay, yeah. Normal. So after giving epinephrine, what do you want to do now?
I'm gonna go back and check her out. Did we do a physical exam?
No, there's no time for physical. She's deteriorating. She's gonna die right now. So really, huh?
What do you mean? We just gave her epinephrine. Why would she die?
No, like she's deteriorating right now. So you want to do physical?
I mean, you can move the clock and see how she's doing with the epinephrine and
Exactly, yeah, smart. So let's just move it 5 minutes only.
Yeah.
And then see how she's doing. Okay, so you repeated she's saturating 82 on room air, 93 on 4 liters oxygen. She's feeling better with 1 dose of epinephrine. Okay, so now that's me good. How about if the patient having severe respiratory distress like cyanosis, stridor, low oxygen saturation, despite of 100% oxygen? So what should you do right now?
Intubate at that time.
Yeah, intubate and mechanical ventilation. So, yeah, good job. So now let's go to the physical. So what do you want to examine?
Pretty much everything. Face, this, that.
Extremities, like other stuff, we don't, maybe neuro, that's it. Okay, so she's very anxious, she's frightened, and mild to moderate respiratory distress. There's no skin rash, face, neck, and tongue are swollen. Pupils are equal and reacting to light. Mucous membrane are dry. And there's diffuse expiratory wheezes. Extremities are acyanotic and swollen. Non-pitting edema is present in asymmetric fashion all over extremities.
Yeah.
So what do you want to do now?
Mm. So edema got better or no?
No, she's still edematous.
So do we only give epinephrine once, or I don't know. How do you?
Now let's do the ABG, CBC, CMP.
Oh, okay, the cut anemia.
Okay, let's do EKG,
Chest X-ray, UA.
chest X-ray. Yeah, and then there is one thing that we give because they have a bronchospasm, so they have wheezing. So
Mm-hmm.
on examination, there's expiratory wheezing. You remember I told you?
Albuterol.
Yeah, so let's give her albuterol and steroid
Yeah, sounds good.
and hydrocortisone and also diphenhydramine.
Okay, antihistamine, right?
Yeah,
Hmm.
and let's give her ranitidine too.
H1 and H2 blockers.
Yeah. Let's do portable chest X-ray. Let's do the urinalysis and albuterol. How do you want to do that? What route? Just nebulization, inhalation.
Inhalation. Inhalation. That works faster.
Hydrocortisone, which is in therapy. Give him IV hydrocortisone. Diphenhydramine IV. Ranitidine IV too. I already had the IV access. Okay. So now let's get the results that we ordered.
Mm-hmm.
Let's just advance it for 1 hour. Okay, so now the ABG PO2 is 70 on 4 liters of oxygen. PCO2 is 30, pH is 7.5, so there's respiratory alkalosis.
Mm-hmm.
BMP is insignificant, and CBC shows elevated white BC to 12,000 and left shift.
Mm-hmm.
EKG shows sinus tachycardia, chest X-ray is normal. So now what do you want to do?
So did her oxygen go up?
No, actually, it's still down. The saturation was 82, but this one is the partial pressure of oxygen, which is 70. So there are two different values.
Should we move? We gave her like all these medications. Should we move the clock a few minutes to see how she does then? Or no?
Yeah, so we moved the clock right now. Now let's put her in the ICU because she require an intensive monitoring.
Mm-hmm.
Let's transfer. Let's do the admitting orders, vitals, uh, panic, omeprazole, bed rest. Okay, put her on NPO, input output. Okay, pneumatic compression,
Mm-hmm.
and then let's do. Okay. No, we examine her every 30 minutes after this. And what else? Like, what if she's still hypotensive despite IV fluid? What do you do?
I can give her Dobutyl. I don't know what to
Excellent.
do.
Yeah, dopamine. You can give her dopamine.
Usually the case ends if you give epinephrine in
Yeah.
the real thing.
Yeah, but we continue monitoring the patient like every 30 minutes. So even if the case didn't end, so now
Yeah.
every 30 minutes we just do quick physical.
Yes.
Okay, now the patient is feeling a little bit better.
Mm-hmm.
Okay, he's improving. And the case will end. You're right, so it will end by this way. Okay, so once the patient improve, what do you do right now? Imagine the case
Move
after.
her to inpatient, maybe?
Hmm?
Move her to inpatient? Or you're gonna monitor her in ICU?
First, let's just continue the IV diphenhydramine, discontinue that, discontinue IV steroid, discontinue IV ranitidine, discontinue IV epinephrine because we had epinephrine. And then let's put cortisol, prednisone oral, and let's give her diphenhydramine oral. Oral and diphenhydramine oral too. Even the IV fluid, we're not gonna need it. Because her blood pressure is normalized now. Okay. So how long do you keep her in the inpatient? Imagine the case didn't end.
I would keep her for 24 hours.
Yeah, excellent. Just 24 hours. You keep her inpatient and then discharge her. Just check on her the next day if she's feeling okay then.
Yeah.
Because that's the acute management, is that you gotta do everything in the first 30 minutes. These types of cases very urgent. So now just do a quick physical and now everything seems alright. Let's do vitals. Vitals are getting better. So no, so you just discharge her. So when do you want to schedule her an appointment?
In a week. Or a few days.
Yeah, you can schedule her in a week.
Did you counsel her?
Yeah, let's counsel her.
Get her an allergy test too. Maybe she has other allergies.
When do we do the radio allergy? When do you do the allergy test?
In reality, you would do it in ABPA. When you have asthma and you have.
Yeah. But this for anaphylactic, how often afterward? Like how many weeks after?
That I don't know.
They say after 6 weeks you do.
6 weeks. Allergy test after 6 weeks?
Let's provide education and medication.
Counseling use of EpiPen.
Yeah. Just give it. Okay. So now what do you want to do?
You didn't move her inpatient? Oh, you don't want to move her inpatient, right?
Yeah, we can just discharge her. There's one thing that I forgot. Let's order like alert bracelet. Like let's counsel her on avoiding allergies and alert bracelet.
But she's allergic to the bee, not like food. If it was food, you can give a bracelet. No, I don't know. I don't know when you give bracelet. I'm just saying.
Actually, even they say like in the thing they say give her allergy.
Oh, okay. Just in case in the future. Okay.
Yeah. Avoid allergies. Let's see if there's anything about allergies here. Allergen avoidance. Order alert bracelet and EpiPen. Okay, so how do you summarize this case? Simple words.
So we have a patient with shortness of breath and swelling, especially of face and lip, after some kind of event like a bee sting, or it could be anything that can cause, and with especially hypotension and tachycardia is considered an anaphylaxis shock. So we need to put this patient stabilized right away by giving them fluids and epinephrine. and then checking on them again. And then if they are still unstable, we can give them albuterol, steroids, and we keep checking the oxygen. And we can give them diphenhydramine, all the supportive treatment to make sure that she is not like, the idea is to stop the swelling in her trachea, so she doesn't go into like unresponsive or something, So, um, and then yeah, we do the, and then we kind of move her into ICU to monitor her every 30 hours to check to make sure that her vitals are stable and her swelling is down, and monitor her and then keep her for 24-hour observation. And when we discharge her, we tell her to kind of, counsel her on how to use the EpiPen if it happens in the future, or carry it with her, and then go for like an allergy test in maybe 6 weeks. And yeah, basically.
Yeah, so good job. But what if the patient is taking beta blocker and presented with anaphylactic shock? How do you treat that?
Ooh.
These patients, you give them a glucagon with epinephrine because this epinephrine may not work with a beta blocker effect.
Yeah.
Okay, and you assess hemodynamic instability, and then you give them the IV fluid crystalloid, and then if it didn't respond to the IV fluid, you give them dopamine. Okay, that's it.
Yes.
And H1 and H2 blocker, which patient do you give H1, H2 blocker both?
Besides this case, you mean?
Yeah, for all patients, they prescribed like H1, H2 blocker initially, and then corticosteroids. This is acute management, and then the the long-term management is that you gotta, maybe we need even to consult allergy or something, like to provide a
Mm-hmm.
formal evaluation. That's it.
Mm-hmm.
Consult allergy medicine. So then, okay, yeah. No, I just discharge her home. We'll schedule her in 2 weeks, and she's good to go. Yeah, and the case should end by then.
Mm-hmm. Mm-hmm.
Yeah, that's good. You managed it properly. Just remember combined H1 H2 blocker, diphenhydramine, and ranitidine.
Yeah.
Okay, plus the dopamine if still hypotensive episode, and you order and then you discontinue the IV medication and to oral.
Oh, you did the RAST test on her?
Yeah, you can have it. Actually, this is what I prefer. In the 2 minute screen, that's what I would better do. I would do the RAST, and then I'll schedule it for later. This is 6 weeks after.
But I thought you said you do the allergy test 6 weeks later.
Yeah, yeah, 6. No, I just wanted to see it in the software. But you
Ah,
do it. Yeah, it's better to wait to the 2 minute screen because this gives you the option to schedule it later.
I see.
But in the
Yay.
active screen, you can't schedule stuff later.
Mm-hmm.
Okay, so that's about it. Let's go to the next one. I think we're almost finishing. Wow.
I don't think so. We have so many left.
No, no, I don't see that there's so many.
Because I check off on my.
No, I don't think there's too many left. There are few. Let's see what's going on here. Okay, so this is the other case. You have a 35-year-old African American male came for routine exam. Temperature is 98, blood pressure is 162/94, pulse 78, respiration are 14.
Who is this person? Sorry.
A 35 African American male. So the full history, he presented to the routine complaint of weakness and anorexia for the past few weeks. His review of system is positive for flank discomfort. Patient is a postal worker. He does not drink alcohol and has smoked 1 pack of cigarettes daily for the past 15 years. His
Hmm.
father died at age of 45 from kidney disease. So this is interesting. Hypertension with a flank mass. You get
Hmm.
your idea. Let's go now.
Polycystic kidney disease?
That's most likely, yeah. Now, first, what do we do? Do we do physical, right?
Yeah, we can do. We came to the office, so we can
Yeah.
give.
So let's do hand, chest, abdomen, extremities, maybe. You get the skin, it's okay. There's the lymph node, doesn't matter. Okay. Examination shows bilateral, palpable, cystic kidneys. Everything else is fine.
Mm-hmm.
So this is obviously autosomal dominant polycystic kidney disease.
Mm-hmm.
Other causes could be congenital simple cyst, medullary cystic kidney disease, acquired cystic kidney disease. Okay,
Mm-hmm.
so
Mm-hmm.
those are the differential diagnoses that we have here. Now let's just order labs. Let's see.
So we can do like CBC, CMP, chest
Good.
X-ray, UA,
CBCs. Oh,
lipid profile.
what
Mm-hmm.
happened?
Uh-oh, uh-oh, uh-oh.
No, nothing. Everything is fine. Now imagine we did the physical. Now let's just do CBC, CMP,
Chest
chest
X-ray,
X-ray,
UA.
abdominal ultrasound, UALT. Let's do FOBT. FOBT. Still we don't need a TSH.
PSA, lipid profile. You did lipid profile?
Lipid profile. Yeah, let's see this.
ESR, EKG. You did EKG?
Yeah, ESR, UNA, EKG, analysis. Yeah, that's a hacks. Yeah, I think that should be enough for now.
Mm-hmm.
Oh, okay. Oh, he's in the office. Okay, I'm gonna change it. It's okay. Okay, so then the urinalysis shows 40 plus RBC negative nitrate esterase. MCV is 88 normal. Uh, serum potassium 6.8. That's the most significant find, and creatinine is 6.4.
Mm-hmm.
Okay, hemoglobin is 9. Everything else seems to be okay. Glucose 118. Ultrasound of the kidney shows bilateral polycystic kidneys. Okay, EKG shows peak T wave.
Of course, because his potassium is high.
Yeah. So this patient's renal failure resulting metabolic acidosis, hyperkalemia, and hypocalcemia and anemia of chronic disease. So what do you do for this guy?
Well, first of all, I'm going to put him on ACE inhibitors. Does he have proteinuria?
No, let's check. No, I think they did. Let's see. No, they didn't
He's
say. They
hyper.
didn't say.
Okay, he's
Then,
hypertensive.
hmm?
And he's not taking anything, right, for his hypertension?
No, no. So he's in
So,
the office. The first thing I would admit him because
yeah.
he's having acidosis, hyperkalemia.
Yes, yes, yes. So, put him in the ED
Yeah,
and
and he
let's
may
manage.
need. Yeah, he may need long-term dialysis.
Yeah. 6.4 creatinine? Wow.
Yeah. So what is the rapid management for this patient? Let's just send him to the inpatient. Let's do the. So now I'm admitting him. So let's do vitals. What else? Omeprazole is not gonna need the to put him bed rest. Diet. Let's put him
In,
on NPR.
input, output,
Input.
nomadic.
Pneumatic compression. Actually, we can give him diet, renal diet. I guess okay.
Yeah, you can give him diet.
Pneumatic compression. What else? Do you want to do IV access? Let's put him. We don't need an IV fluid here. Now his EKG finding is scary, right? So let's just give him calcium gluconate.
Yeah, that should take care of the potassium and the EKG.
And what else? How do we manage hyperkalemia? What else?
Okay, excellent.
Yeah, that's another one. Yeah.
Or I can give insulin too. He
Excellent.
has.
Yeah, that's what I was waiting for you to. Insulin,
Uh-huh.
D50. That's also.
Yeah. Insulin can push
So those
potassium.
are all the so calcium gluconate only to prevent arrhythmia, stabilize the cardiac membrane,
Yes, yes, yes.
but doesn't fix the actual problem going on here. Just complete.
I don't think they have a renal. You just, yeah, low protein. Okay.
Just put on the protein. Running dextrose. Okay. Now let's put the cardiac monitor. This is a big thing, you know.
Yeah, cardiac monitor, BP monitor. We didn't give him anything for hypertension. Can we please give him something?
Like what? What do you want to do?
I don't know, anything. I don't
Let's
know.
manage his hyperkalemia first.
Okay.
Yeah. So now let's consult nephro.
Hmm.
Okay, and let's repeat BMP every 4 hours and CBC also.
Mm-hmm.
And let's order phosphorus, magnesium.
Yep.
Let's do iron, ferritin. So what do you want to treat his hypertension with?
It's a secondary hypertension.
Yeah, so what do you want to give him?
Um, I don't know. I'm between ACE and thiazide.
He's gonna damage his kidney. His creatinine is 6, right? Like,
Oh yeah, and it causes hyperkalemia. Um,
let's give him amlodipine. That doesn't affect the situations. Yeah, and worsen hyperkalemia too. That's another thing too. So now he's having hyperkalemia, chronic kidney disease, and anemia of chronic disease. Okay,
mhm.
so we're managing 3 conditions at the same time. Roger console, whatever. PMP does do every 4 hours. This is scary. CBC do it every 4 hours. Maybe need transfusion and stuff. So let's just do it one time. Maybe next soon. Let's just check everything.
Can we do a head CT to rule out berry aneurysm?
That's a really good thought. I like it. It's more for a follow-up, but we can do it maybe later. Let's just see what type of anemia he's having right now. I think let's manage his condition. He's hyperkalemic and he's in a tough situation right now. and then we monitor that. CT is a screening, right, for that. Okay, so now his phosphorus is high, and the iron studies indicate anemia of chronic kidney disease. So what's your best next step? So now you have hyperphosphatemia. You added. How do you treat that?
Yeah, he would have hyperphosphatemia because kidneys aren't getting rid of the
Yeah.
phosphorus.
Yeah, and he's having
And
hypocalcemia. So let's give him erythropoietin for the anemia of chronic kidney disease, right? How about that? What do you think?
yeah, and also vitamin D because vitamin D is not being absorbed.
Give him vitamin D, and I'm gonna give him calcium.
And calcium, yeah.
And you remember there is one thing that is erythropoietin is subcutaneous. There's one thing that we have to give with erythropoietin. You remember?
Um, I forgot. With erythropoietin has its own side effects too.
Hmm?
Hmm?
This we gotta give. We
Eryth-
gotta give iron because erythropoietin
yes,
increases the risk of
yes. It
so it
induces
can
iron deficiency.
induces iron deficiency anemia.
Yes, it does.
So
You
this.
have to give iron. Yes, yes, yes. Good.
That's what we want to do. Okay, so now there's just anything else you want to do?
I think no, that should be good.
Okay, now we just follow up with him. It's just it's tough, very tough. Like this kidney disease, like it's crazy.
Mm.
We had a patient who had an autoimmune reaction, and that damages his kidney, damages the brain. It's crazy. So they wanted to withdraw life support, and he has no support, no family whatsoever. So
Mm.
he's living on mechanical ventilation. So they wanted to disconnect from the ventilator
Mm-hmm.
because he's not responsive like for a week or so. And his neighbors were with him, so they said, yeah, that's okay. You can discontinue next morning.
Oh my God.
Yeah, so they wanted to discontinue. Next morning he wakes up.
Oh, are you serious?
Yeah,
Look at that.
yeah. But even when he wakes up, he can't talk. He can barely listen. Like he's very tough. Like he's just like minimally responsive. Like, so it was
Oh.
very interesting. Yeah, it was the end of my rotation, so I didn't know what happened after that.
Mm.
It was very interesting.
What school did you go to?
Mm, okay. So now, what do you want to do at this point?
I don't know.
His
He's in.
his potassium is getting better, and
Mm.
a little bit better. I think he's gonna need dialysis for sure.
Think so. How's his creatinine?
Yeah, but I think this is beyond step 3, maybe. This is nephrology.
Yeah, this is a hard case.
Yeah, it's multiple thoughts. Yeah. Let's just check on him, see how's he doing. Ouch. You know, if you do step 3, you can do nephrology fellowship if you want.
Mm-hmm.
Some programs. Do you know anyone who did that?
Yes, I have a friend.
Yeah, the residency after. Yeah, so now he's a little bit better and stuff. So what do you want to do right now? You want to consult?
Sure. So, what medication, BP medication, you are going to discharge him on? Because he's always going to have hypertension because of the
Yeah,
polycystic.
I would give him amlodipine. That would be a good thing. What do you think?
I don't know.
Yeah, they didn't even discuss it here, so I think it's a little bit more complicated. You know, that's why they did residency, like you can learn way more stuff. Limit alcohol, limit no smoking,
Mm-hmm.
no alcohol, no smoking, no illegal drug use. Okay, yeah, so that's about it for this case. So how do you summarize this case?
So we have somebody with a young person with hypertension. You have to think of differentials and causes of secondary hypertension. Renal causes are the second more common cause of secondary hypertension, and in this case, we are going to find out through some diagnosis such as ultrasound and that this person has polycystic kidney disease. Now, once we run his labs, we find out through EKG, through CBC, that this patient is having peak T waves, hyperkalemia, also, what else? What was I gonna say? Yeah, so basically we kind of control his potassium, give him insulin, D50, we give him Kexalate, control that, and normalize his EKG, especially calcium gluconate because we don't want this potassium to affect the myocardium, the heart, right? Once we stabilize that, then we have to work on his creatinine. We give him IV fluids. We kind of did we put him into dialysis? Not yet. Okay.
No, no.
Okay. We just check his phosphorus levels, and then we give him erythropoietin. And once we give
So
erythropoietin,
what are the indications for giving erythropoietin in this
um,
patient?
I think phosphatemia,
If the hemoglobin less than 10,
hemoglobin less than 10. Okay.
yeah, yeah. And what if the creatinine is 2? What antihypertensive do you use for this patient? So if 2, then you use AC inhibitor. But if it's more than 2.5, then
Mm-hmm.
you use amlodipine to treat hypertension.
Say that one more time.
So the management of hypertension and polycystic kidney disease depend on the creatinine. If the
Um,
creatinine 2.5, then
yeah.
or lower than that, then you give AC inhibitor. If it's more than
Oh,
2.5, you gotta give calcium channel blocker. Okay,
that's indication. Yes.
and you gotta order low like renal diet, which is low potassium, low protein, and low phosphorus. So you can select those. Okay.
Mm.
What is the only medication that removes potassium from the body?
Thiazide? I don't know.
Kyaxalate is the only one that removes it from. So insulin it trickles it inside the cell,
Yeah.
but the kyaxalate is the only one that takes it out of it.
Yeah.
And once the treatment is given, you gotta check potassium 4 hours after.
Mm-hmm.
Okay, if it's still high, then you gotta treat him again. Repeat the same thing.
Mm-hmm.
If it's still high after the second round, then you do dialysis.
I see.
Okay, so that's the indications for it.
We do a nephro consult. We give them we do iron studies. We give them iron along with erythropoietin. So those are all key things.
Yeah, you're right. So that's about it. As I touched the main things in management of acute chronic kidney disease. So those are the main things that we need to focus on. Okay, so now let's try to do one more case. Okay, now you have a 68-year-old white female who lives alone at home and presented to the ER with sudden onset of low back pain while removing a turkey from the freezer. Her vitals is temperature is 36.7, blood pressure is 120/76, pulse is 80, respiration is 16. Okay, so now let's take the full history from her. Okay, so she had this sudden back pain after removing a heavy object. The pain 10 out of 10, constant with no radiation. She never had this pain before. She denied weakness, sensory changes, or bowel, bladder incontinence. She doesn't have fever, chills, or any of that. Okay, since the age of 53, she has been postmenopausal and not taking hormone replacement therapy. Okay, so that's a big flaw. Her other only medical problem is the high blood pressure, which she takes hydrochlorothiazide, which increases risk for osteoporosis too. Okay, she smokes 1 pack of cigarettes per day for the past 40 years. You got a counselor on that. Okay. Occasionally she drinks alcohol. Her pap smear was 6 years ago. It was normal. Last mammogram was 1 year ago, so you don't need to do that. Colonoscopy was 5 years ago, so you don't need to do that. So you gotta do DEXA scan. She's 68, and you gotta counselor on alcohol, smoking, and you give her influenza, pneumococcal.
And colonoscopy.
Colonoscopy 5 years ago it was done.
Oh, okay. So it sounds like she has a compression fracture.
Let's see what we can do for her. So review of system, anything else is negative. Let's see what we can do. She presented to the emergency room, by the way.
Yes.
Okay. So now what do you want to do?
So, of course, we're gonna do the basic.
Let's do a really quick physical, because she's stable.
Okay.
Okay, there is severe tenderness over the L3, L4. Straight leg testing is negative. Anal sphincter tone is normal. Neuros unremarkable. Only severe pain and tenderness at L3, L4. So what do you do? What do you want to do here right now?
So I'm just going to. Are we gonna do the V panic thing? I mean, not V panic. Sorry,
Police, yeah, the
police.
police. Let's do it. Why not? Oxygen pulse, oxygen, IV excess, IV fluid, cardiac monitor, BP monitor, fingers, take a glucose. Let's do CBC, CMP. Let's give her IV medication, Toradol or Ketorolac. Let's do X-ray. Okay, of the spine, lumbosacral. What else? Let's do ESR. That's an important one.
Are we gonna do Actually, no, that's fine. Yeah. Flip the profile.
TSH
EKG.
and these stuff, not important. Let's do EKG. That's a good one. Okay, so CPC, LFT, TSH, LFT. I see. Okay, yeah, I think that's about it right now. Just the analysis. What else? Do you want to do anything else? Yeah, maybe. And then maybe let's see what's going on. Let's order calcium, magnesium, phosphorus. Okay, let's go.
ETH.
What is that, BP?
Hmm?
What did you say, BP?
No, I said PTH.
Oh, yeah, that's a good thought actually. I'm gonna order that too. spine, lumbosacral.
Mm-hmm.
Make sure this one will give it one time. Okay, so now what do you want to do? You said PTH. That's a good one.
Hmm. We should
Let's
move
let's
the
let's let's check the X-ray. Let's check the X-ray on the
yeah.
heart of
We
it.
should move the clock and see the X-ray and see what's going on.
Pulse is okay. Glucose is fine. Let's see. Blood pressure is okay. Monitor is fine. EKG is fine. Urinalysis is fine. Calcium is okay. Ccs is fine. Okay, so the X-ray shows diffuse osteopenia and vertebral compression fracture of L3, L4.
Yeah. So she probably has osteoporosis, and then she got the compression fracture from the event, from lifting something heavy.
Yeah. So now this is something serious. Let's do.
Steroids. No, not
Huh?
steroids. No, 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 no.
Let's do. It could be. Let's do electrophoresis. Could be myeloma. Let's do PTH. Okay. And let's give her calcium,
Vitamin D.
vitamin D, and she's feeling better because of the toradol. So I'm gonna give her naproxen
Mm-hmm.
oral. The toradol just initially. And then what else? What do you think? What indication of what medication here?
Methylprednisolone.
Huh?
Uh, are you gonna give her
Alendronate, huh?
alendronates? Yeah.
Yeah, because remember there are 3 indications for management of bisphosphonate. Like when there is a history of a fracture or a DEXA scan more than 2.5, or the fracs more than 20% in any bone or more than 3% in the hip. So
Mm.
any of these, you have it, you gotta order aldronate, and you can give it for Paget disease too. And
Yes.
then let's change diet. Let's give her calcium-rich diet.
Mm-hmm.
High calcium diet. Okay.
Mm-hmm.
No, just follow up, eh?
Yeah.
We just keep her for a couple of hours. Like we're not gonna keep her now.
Mm-hmm.
It's just.
So what do you do about the fracture? It heals on its own.
It's different. Like if it's severe fracture, may require surgery. If it's compressing the nerve and stuff like that.
When in which kind of back problem do you give steroids? I forgot. Which one was that?
Yeah, that's a good job. When there is a spinal cord compression.
Oh, spinal cord compression. Okay, okay,
And you
okay.
gotta make sure, so the spinal cord compression present exactly the same symptoms as
Yeah,
epidural abscess. But epidural abscess have fever, so you gotta make sure if the patient have fever, never give a steroid.
yeah.
Yeah, so that's that's about it right now. Did we order DEXA scan? Let's get her
No, we didn't. We have to order DEXA scan.
DEXA scan. And what else that we said that we need to? Pap smear, she doesn't need that. Mammogram,
We
she done it.
can
Colonoscopy, done it.
gout her.
Vaccine, let's give her vaccine. and
No smoking and all that stuff. We
yeah,
cancel
counseling and stuff.
education. Limit alcohol because alcohol can cause osteoporosis.
Yeah, you're right. I'm gonna tell her no alcohol.
Um, that's it, right?
Okay, let's see. This is annoying. Like that's the thing annoying. Like when you choose the counseling and
Mm.
so many things show up.
I type the whole thing and only that thing comes up. Whatever I want to cancel on.
But this is gonna take more time. Yeah. Yeah, that's a good idea. It's gonna take more time.
I type fast, so I could do it. I do it all the time.
Yeah, so that's good. That's at home. Give her exercise programs, effective medications.
She needs to do weight bearing exercises. Yeah.
Hmm?
Weight bearing exercises.
Yeah, so that's good so far. Let's go. Okay. Everything was cancelled and everything. Okay, so now how do you summarize this case for me? We did almost everything. There's nothing much to be done. That's the main thing is that you diagnose it with a spinal X-ray, and then you give them the pain, you relieve their pain, and you give them vitamin D and calcium.
Mhm.
That's it. Management of different types of fracture, I think it's beyond our scope of step 3. It's more
Mm,
likely orthopedics. Like they do 4 years of residency. That's their job. Okay,
right.
so now how do you summarize it?
So we have an elderly female who had sudden back pain after an event, and she comes to the ED, and we kind of have to do an X-ray to see what's going on and give her pain medication because she's in a lot of pain, and the X-ray shows compression fracture, right?
Mm-hmm. Yeah.
Now we we order pain medications. We also give her bisphosphonates. We give her calcium and vitamin D because that's going to support, um, kind of her bones. And basically, I think that's it, right? And we can also kind of check to rule out other disease cause of bone fractures or bone, like we can rule out Paget's, we can rule out multiple myeloma. We order tests to rule out things like that,
When
like
when do
type.
you when do you order MRI?
You order MRI when there is an vertebral osteomyelitis or a vertebral abscess
No, clinically, yeah, you're right. Yeah, when there is like fever and you suspect osteomyelitis, or when there is a neurological abnormalities.
or neurological abnormalities.
Okay, if the MRI is abnormal, then in this case we refer for orthopedic surgeon.
Oh, okay.
Okay, and and how do we rule out myeloma?
You do the serum protein electrophoresis.
Yeah, SPEP, science important electrophoresis you have, or urine Benz Jones protein can work too. And so now for these types of patients, non-steroidal is better than narcotics.
Mm-hmm.
And early mobilization is the best treatment, is the
Mm-hmm.
mainstay of treatment.
Mm-hmm.
Okay, so what are the secondary causes of osteoporosis?
A long-term steroids, Cushing disease.
Yeah,
Mm-hmm.
yeah. So the thyroid, like hyperthyroidism,
Mm-hmm.
parathyroid abnormality, Cushing disease. And then we gotta give them calcium, vitamin D, and bisphosphonate should be given. to
Mm-hmm.
prevent osteoporosis and the second fracture. That's the key.
Mm-hmm.
It's very tough. Like one time we had a patient, she had a hip fracture,
Mm-hmm.
and then we treated her and everything, and they put her on rehab, okay, physical therapy.
Mm-hmm.
And this guy in the physical therapy, she was a little bit like pushy on her, so she fell and fractured the second hip.
Oh my God.
Yeah, it was
Oh,
very tough. And she's back in the hospital.
oh no.
And that was a big lawsuit. Like, yeah,
I
and
think all always a big lawsuit because that should always be preventable.
that's true. Yeah, and then plus the calcium, vitamin D, you gotta counsel her about the risk factor, preventable risk factors, prevent
Mm-hmm.
them before it happens. Okay, so now imagine if I change the scenario. If I tell you this patient present with a tearing abdominal pain radiating to the back, associated with nausea and vomiting, then what would be your diagnosis? And plus an equal blood pressure on both arms.
Aortic dissection?
Yeah, I took this. How about if I tell you pain radiating to the back with unstable vital signs, abdominal bruit and pulsatile abdominal mass? What is
Triple
that?
A, triple A rupture?
Yeah, abdominal aortic aneurysm. That's okay. How about if there's how do you how about if there's a malignancy? How do you know that?
Malignancy?
Mm?
Like in terms of, in you mean
Like
in clinically?
yeah, metastatic causing metastasis to the spinal cord causing back pain.
I'm not sure.
So there is weight loss,
Oh,
loss
like
of
okay. Yeah,
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 loss of appetite and thin
yeah,
body
yeah,
habit, smoking,
yeah, yeah.
and they may have a history of lifting heavy object.
Hmm.
Okay, and malignancy should be ruled out in elderly. This is very important to rule it out,
Yes.
and we got to do age appropriate screening. But as
Mm-hmm.
they did it, if they didn't do it, like well, then we do everything.
Mm.
Okay, how about if you have back pain and paresthesia radiating down the leg in a dermatomal distribution? What is that?
What?
Back pain radiating to the lower extremities. Then what type of back pain is that?
Is that sciatica?
Yeah, disc prolapse with or
Yeah.
without cord compression, sciatica. How about if I tell you there is a paravertebral muscle spasm
Mm-hmm.
without focal spinal tenderness?
Mm-hmm.
This is very important. So what is that?
Paravertebral.
Hmm.
That's just lumbar strain.
Excellent. Yeah, just numbers. How about if I tell you sudden onset of back pain with lower extremity weakness and bladder and bowel incontinence, plus
Oh,
saddle anesthesia?
oh, cardiac vena.
Correct. Okay. How about if I tell you sudden episode of back pain with a history of hemophilia?
Ooh, back pain with hemophilia.
This is epidural hematoma, most likely could be.
Okay.
How about if I tell you the patient is diabetic, has renal failure, and is IV drug abuser? He's having fever, radicular pain, elevated white BC, with left lower extremity weakness. They can have lower extremity weakness, or they may not. They may have compression or not compression. So, what's your diagnosis for this case?
They're diabetic, they have fever. What about neurological?
No symptoms in neurological. It's not important. Like they may have neurological findings,
Oh,
and they
if
may
they
not.
are IV, if they're IV drug user, they get osteomyelitis of the spine.
Yeah, most likely to be an epidural abscess. That's also most likely. Hmm?
Yeah.
Okay. So when is your exam?
It's next week. Can we do one more case?
Yeah, that's what I'm saying.
Short,
When?
a short
Yeah.
one.
When is your exam? It's on 28 and 29. You said?
Yeah, yeah,
Huh?
yeah.
Oh wow, that's cool. Wow.
Mm-hmm. I'm excited. I want to give it away because I'm so
Yeah.
tired of studying every day.
Yeah,
It's just
that's true. Yeah, but that's
been,
I like it's usually harder if you do it one after the other one. Like,
yeah, I don't have a choice. I didn't get anything, you know?
yeah, yeah, you're right. Yeah, I see what you're saying. Yeah. It's booked,
I
all booked. It's okay. Okay, so
do
now.
a short, quick one.
Hmm?
A short, quick one.
Yeah, that's the short, quick one.
I know you have to go. You have to go, right? If you have to go, that's
No,
fine.
no, no, that's okay. Let's do another one. That's a 28, right?
How much? How many more do we have left? We have one,
Yeah, let's see. Let's do another one.
two,
I don't
three,
think there's not much. Okay.
4, 5, 6,
Okay, so let's. Huh?
7, 8, 9.
Okay.
We have 12 more cases left.
Okay, now you have a 43-year-old African American male presented with easy fatigability.
Hmm.
Temperature is 36, blood pressure is 120 over 76,
Hmm.
respiration 16, pulse is 80. Okay,
Hmm.
so his full history, he denies cough, breathing problem, constipation, diarrhea, melena, bleeding per rectum. So he's
Mm-hmm.
just having fatigability. Past medical history is nothing significant. He was incarcerated for driving under the influence. He has
Hmm.
been drinking 7 to 8 beers per day for the
Hmm.
past 20 years. He smokes one pack of cigarettes daily for the past 22 years. He denies IV drug use or multiple sexual partners. He's construction workers. His diet mainly tea and toast. Okay, so what do you do with this patient?
Tea and toast diet.
Alcoholic, easy fatigability. Yeah, so it's kind of like something benign. Okay, so now what do you want to do?
So he just came for fatigue.
Yeah, alcoholic,
Is
most likely
he
macrocytic anemia, right? Like alcoholic, poor diet and stuff.
thinking more like
Folic or B12,
hepatitis?
huh? What is it?
Hepatitis, because he's immunocompromised if he
So he
drinks.
doesn't have right upper quadrant pain or anything. I don't. Let's see. Could be anything. So
Okay,
what do you
fatigue.
want to do now? Let's just do
Oh,
full.
fatigue could be thyroid problem. It could be anemia
Could
problem.
be anything. Yeah, the thyroid could be anything. Yeah.
So we need to run some tests
Let's
to
do
narrow.
physical first, and then let's do
Yeah.
everything. Full physical. Fatigue.
So,
This is a crazy case.
yeah.
Okay, so a mucous membrane and skin shows pallor, no lymph node.
Mhm.
So that's about everything is fine. So it's most likely has anemia.
Mhm.
It looks like most likely he's having iron deficiency anemia. It could be a GI bleed, gastritis, cancer, or it
Okay.
could be megaloblastic anemia, like folic or B12, or it could be anemia of chronic disease.
Right.
So that's what the differential. Now let's see. Let's order. Let's do CBC,
CMP,
CMP,
X-ray,
just X-ray. Let's do
UA.
lipid panel.
I'm using my mnemonic.
I'm using my
UA.
iconic too.
Oh, you're using your mnemonic. Okay, okay, that's funny.
LFTS. Yeah, let's do stool. ESR. I'm using bigger mnemonic, like
Ah,
humongous one. The one the CBC,
okay.
LFTS. Okay, the ICU packs. You know
Yeah, I
that.
saw that on the forum. Yeah.
Yeah, packs. That's amylase, PT, PTT. I like fatigue
Can
cases.
we do iron studies?
That's a good one. Yeah,
Can
ferritin.
we do can we do liver panel? Only because I feel like he's an alcoholic.
Yeah, yeah, that's true.
His GGT could be high.
Yeah, that's true. Let's see. Hmm. Let's do this one.
Are we gonna do any imaging on him? Oh no, he's just fatigued. Never mind.
Yeah, just for you.
Did we do TSH?
Yeah, that's it. Do you want to do anything? I don't know why they have a stool for ova and parasite, stool ova and parasite. Do you have any idea?
No.
It's confusing. Okay, so what else do you want to do? Fat, maybe pancreatitis.
Why you are in stool studies? Did
Because
he
fatigue,
complain?
it could be pancreatitis, pancreatic cancer, it could be colon cancer. So I'm just doing occult to blood and
Just do FOBT, and if there is blood, then we can do stool cultures, no?
yeah, yeah,
I mean, FOBT, or I don't know. Okay, it's up to you.
yeah, but
Maybe,
doesn't hurt. Yeah.
yeah.
FOBT already did it.
They're not even gonna come right away anyway.
Yeah, you're right.
Yep, that's good.
And then what else that I wanted to do? A peripheral smear? Let's do.
You should also order homocysteine level and
Mm,
methylmalonic acid because we don't know what if he does have macrocytic anemia. We would know which one is it due to.
yeah.
Keep going. THY. There you go. No?
Mm, where?
Methyl mal. Oh,
It's okay. We can do it after the MCV.
it's
Hi.
fine. It's fine.
Okay, so now let's just send him home, bring him back. So you look at the thing. Most
Wait,
of them gonna be there by day 3.
oh,
So
so
let's
we're not gonna give him anything for his fatigue.
let's. Hmm?
At least find out TSH. That's gonna come right away. At least find out iron studies. That's gonna come right away. Because if it is iron, we can give him iron supplement and let him go.
Yeah, you're right. Yeah.
Or if it's TSH hypothyroidism, then we can give him medication and discharge.
Yeah. Yeah, you're right. But we can. I'm just bringing him
Oh,
back in 3 days. That's
oh.
still fine. Okay, so now the MCV is 118.
Oh, megaloblastic. I mean,
Yeah,
macros.
BMP is fine. HB is 9.
Mm-hmm.
Okay, peripheral smear shows hypersegmented neutrophil.
Mm-hmm.
Okay, so now
Oh, you know what? These people who are alcoholics have deficiency of folic acid.
yeah, you're right. Yeah, that's what I'm saying.
So maybe that's what it is. So macrocytic anemia could be due to folic acid.
Yeah, so now let's just do a quick checkup on him and see how's he doing. Then we order folate B12.
Mm-hmm.
Okay, now let's just do B12. Let's do reticulocyte count,
Mm-hmm.
and I'll give him folic acid therapy.
Mm-hmm.
What else do you want to do? I'm gonna give him B12 therapy too. What do you think?
Why?
Because macrocytic, it could be either one. Okay, I'm gonna give him also iron.
Yeah, I think we should give him iron, folic
Give
acid.
him
Thiamine.
thiamine,
Yeah, sounds good.
multivitamin,
Mm-hmm.
and
Counsel,
iron-rich diet.
counsel him. Don't smoke. Don't drink.
Yeah, folic acid therapy or iron. Give him thiamine. Multivitamin, we give him regular. Diet, rich iron.
Mm-hmm.
Okay. Vitamin B12. Vitamin B12. Order serum and therapy at the same time. Okay, so now you want to counsel him, yeah. So let's counsel him about alcohol use, driver's seat, about education.
He was a younger. How old was he? He was
That's 43.
oh,
No alcohol, no legal. You do relaxation technique after step 3 too.
sorry.
You do relaxation technique before and after step 3.
I know.
Yeah, you need that. I'll,
I am.
I'll order counseling for you. Don't worry, I got you.
I know. I can't wait for this to be over.
Yeah, yeah, but you got also residency too. Like it's not that bad. Even residency is not as
I
bad.
want to enjoy residency. I
Yeah,
don't want to worry about taking the step exam.
exactly. Yeah, you're right. This will be more fun, like see people and stuff. Okay, so
Yeah.
now let's just schedule him for the next week.
Because you know what happens? As much as you think you will learn, you will also forget CK knowledge.
You're right. Yeah,
Mm. But your residency doesn't teach you CK theory, they teach you practical stuff.
yeah, that's true. Yeah, you're right. Yeah, it actually works. Yeah, it really works. Okay, so the folic acid is decreased is 1.1, 1.5. Okay, normal is 6 to 15.
Yeah.
LFT and B12 is fine.
Okay.
Reticular site count is low.
Mm-hmm.
Okay, so what do you want to do right now on the next visit in 1 week? He's gonna be here in 1 week.
Check his CBC again.
What else?
Um,
I want
I
to
don't.
discontinue B12 because there's no need for it because it's normal.
Okay, makes sense.
Do CBC again.
Mm-hmm.
That's a good one. Yeah,
I
nothing.
I only give thiamine to somebody who comes in with unknown, like you don't know if what they cook in the evening.
What is it?
I thought for thiamine, I thought you only give thiamine as a cocktail drug.
Yeah, but this guy is taking alcohol. He's a chronic
Hmm.
alcoholic, so he probably thiamine deficient.
Hmm.
So I just give him the stuff. Like, so now he is 43-year-old. There's not much that you can do. What else do you want to do? Like that's it. I think maybe vaccine. We did counseling. Influenza, pneumococcus. There's no need for that. No, no, supposed to be later, but that's okay. Okay, so this one, megaloblastic anemia, within how many months it developed?
I think it takes about 6 months.
Yeah, for folate deficient.
Yeah, because there are a lot of folic acid stores in your liver.
Yeah, that's in normal people. But what if in someone alcoholic? How long is it gonna take?
3 months. I don't know.
Yeah, it's gonna take 5 to 10 weeks. Good job. Yeah, and especially if the diet is poor, low on folate,
Yeah,
like this guy.
right.
So what other medication cause folate deficiency?
Methotrexate,
Yeah, TMP also,
TMPS.
trimethoprim, anticonvulsant,
Mm-hmm.
malabsorption like tropical Cipro, IBD,
Mm-hmm. Oh, celiac sprue. Celiac disease.
pregnancy, lactation,
Mm-hmm.
hemolysis, exfoliative skin disease.
Mm-hmm.
Okay, so that's the thing. Okay, so this patient have all the risk factor to be folate deficient.
Hmm.
So that's why there's no need to get iron studies. But
Yeah,
you can get it anyway, that's okay. Patient,
because it's
hmm?
fatigue, so you don't know it could
Huh?
be any.
What is it?
Because he presented with fatigue, that's
Yeah,
why.
you're right. Yeah, yeah, but that's okay. It doesn't matter even if you're tired. Okay. How about if the patient with folate, his anemia did not get corrected? What do you do?
Oh, you give him iron.
Yeah, you give him iron because this could be iron deficiency anemia. Yep, and that's about it. So let's do a rapid revision of what we discussed for today. Okay. So we discussed this guy who's alcoholic and doesn't eat. So you want to order CBC. You found an increased MCV. So you give him folate and B12 and test for folate and B12, and you give him thiamine, iron, multivitamin, iron-rich food afterward, and just follow up with him. That's it. And then the guy before that, the 68-year-old female, she presented with a back pain, sudden back pain. First thing, you want to give her IV medication, IV Toradol, and then you do X-ray. Once you confirm compression fracture, you give her oral pain pills and calcium, vitamin D, and aldronate, and you counsel her, and that's it. And then the one before that, he was 35-year-old guy. First you do history, and then you do CBC, BMP, and all of these kind of stuff. He presented with no weakness, anorexia, and he has a somewhat dominant polycystic kidney disease. So the best thing to treat that, this is having hyperkalemia, hemoglobin low. After ordering CBC and stuff, you give him erythropoietin, insulin, calcium gluconate, diaxylate, I mean. Okay, and just follow up with him.
Yeah.
And he should be fine and good to go, counseling and stuff. And you can treat his hypertension by amlodipine with the creatinine more than 2.5, ACE inhibitor if it's less than that. And then the one before that was a girl presented with a shortness of breath that started after a bee sting. So the way to go about that, you give her epinephrine, advance it for 5 minutes, see how she's responding. You give her IV fluid. If she didn't respond, give her dopamine, give her epinephrine one more time. And then you add a steroid too, and give her 2 antihistamine, like
Yes.
ranitidine, okay, and
Wait,
diphenhydramine.
we gave her steroids?
Yeah,
Okay, yeah.
yeah, steroid, hydrocortisone, because this is IV, not prednisone. You give her albuterol, diphenhydramine, ranitidine, and then transfer her to the ICU, keep her for 24 hours,
Yes.
and just follow up with her on the next 4 weeks for allergy testing, and that's it
Yes.
for today. Okay, and that's the end of a discussion for today. Okay, so do you have any questions, concerns?
No, Mo, that's it.
Okay, how do you like these sessions so far?
It's okay. It's a good review.
Okay.
Yeah, it's good that you discuss the stuff after we do the case. That's what I like the most.
Okay, sounds good. Yeah.
Because there are differential diagnoses. So it's good to know those and how to manage those and how do you pick up on those because they can give you anything,
You're right. Yeah, that's true. Yeah, you're right. Okay, so we'll see you tomorrow then.